Well, first, thanks very much for having me. I'm actually a UT groupie. Been following the work you've been doing here for a long time, and have had a chance to work with a number of you. So I totally agree with Sal. Despite, you guys may have heard we had an election in the United States recently. So, despite that, it's been really fun. I think we're on a very similar journey. We're kind of in this kind of both parallel process, but there are a lot of cross connections that I think are very exciting. So Susan asked me just to talk a little bit about what we've learned so far, so I'm going to kind of give you a national perspective, and I just want to warn you in advance there may be some alternative facts in my presentation, so just hang on for those who've been following this. All right. So I'm just going to do a quick review because I think it's always helpful to kind of go back to about where we came from. And competencies have kind of become the norm in many ways, but it's not necessarily a new idea. There began to be signals in the 60s and 70s that things were not all well, both in healthcare delivery but also in education. And Bill McGahey, also writing with George Miller, the famous Miller Pyramid, wrote this report for the World Health Organization in 1978. And the thing I really want to highlight about this one piece out of the intro was that the goal is really to train a health professional at a defined level of proficiency to meet local conditions and local needs. I think that's really important, right? That's why we're here. We're a service profession. And so the competencies were a way to begin to define what that service should look like. And more recently in 2010, Frank and colleagues, as an international group of authors, kind of basically took a look at where we'd been the last 100 years. As you can see in the slide, that kind of curricular-driven model really is what flowed out of Flexner. And if you go back to Flexner, because remember, Flexner looked at both the States and Canada, right, when he reviewed schools, there really wasn't any systematic approach to curriculum in many schools. And so Hopkins and Toronto and others kind of served as an exemplar about what medical schools should look like, and thus was born the 2+2 model. And that served us really well, for about 100 years. But part of the problem was it was always driven mostly through expert consensus and was pretty rigid. And what we began to realize, particularly in the 80s and 90s, as you began your journey with the CAN-Med roles and we began ours, is that, again, this return to the health and healthcare needs of our systems that really what should be the primary driver. And from that flow the competencies, right, the abilities we expect of our trainees that should connect to the outcomes of interest. For Marku, it's a successful joint replacement. Having a wife who had to go through a joint replacement at a relatively young age, I can assure you I was freaking out through the whole process, making sure that she was going to be okay. And that's really important. And so, and this is what didn't translate, I apologize. But the ultimate, goal, for us as an outcome is what we call the triple aim. The triple aim is really the way that we think about healthcare in the States. It's the health of a population based on the cost, right, value, and the 6 IOMs of quality, which your care should be safe, effective, patient-centered, efficient, timely, and equitable. And as you know, we don't do real well on any 3 of those domains in many areas. And so that's really been a major driver for competency-based medical education. It's always important for me to kind of go back to that. There was a lot of concerns about people's abilities coming out of training. We had this, quote, uneven product problem. There was gaps in the type of training. I think you've heard that being able to really recognize that has been helpful. And then we had very inflexible training models. I'm an internist by training, and I was always struck that I called it the pluripotential stem cell phenomenon of training. We're going to make sure, Eric, you're exposed to so much stuff that you won't be able to be good at any of it, right? So all these rotations. And there's some truth in that. I had to relearn a fair amount of medicine once I left training. And as we think about the fundamental principles, these are just a couple of those. One, really this focus on outcomes, based on the competencies. And I think that's a healthy thing, right? We really should be able to have a good sense of what people can do when they leave us. And that it really should be, again, linked to the needs of patients. And the reason for the competency frameworks and the EPAs and other things I'll get into a little bit later in more detail is that they serve as a framework or mental model to help guide our training so we don't forget certain things that are really important. I was sharing with Sal earlier that I literally had somebody from a surgical discipline stand up at the end of a 2-day meeting on the 6 general competencies and what we needed to do with them and say that systems-based practice didn't apply to them. I mean, it's just like, and I had to ask him, I said, well, you discharge patients, right? He goes, yeah. I said, they have wounds, right? Well, yeah. I said, well, how are you going to manage that? What are the systems that help patients do that? So, this is a real journey and it takes time, but with that lack of a shared mental model, it's hard to get there. This is one that I think you in Canada have been really terrific at exploring, and that's how we use time. I personally think the duty hours conversation in my country has been probably one of the most dysfunctional. We're still arguing over it 30 years after Libby Zion, and we still see time as an intervention. It isn't. Time's a resource, and we need to use it well, and that includes our faculties. You just heard from the panelists. Really, our training should be in an explicitly defined progression. That's why I'm so enamored of the work of Marcoux and his colleagues, Bill and Peter and Richard, is that they really thought about that, right? You saw those phases. They really thought about how do we make sure that this is truly a progressive experience instead of just a building block model, right? What does it look like as people progress through? Because that's what happens. And then learning has to be tailored. I saw some evidence of that. And then as somebody who's been working direct observation for a number of years, I was ecstatic to hear the three of them talk about the importance of direct observation. It's really critical. I mean, you can't give good feedback on a lot of these skills without watching, right? You just can't. I mean, the feedback's only as good as the assessment information that informs it. And then finally, assessment really has to be planned, systematic, systemic, and integrative. And that's a challenge for us. And what you saw in the three panelists before, again, are examples of developing assessment programs, right? It's not just this tool or that tool. How does it fit within a package? So let me just briefly describe our journey in the US. We began a little bit after you. You released CanMeds in roughly 1995. And there were signals at the ACGME in the early 90s that we needed to begin to take outcomes more seriously. And so we watched with great interest what was happening here. And so in 1997, David Leach was hired, and he began the work toward competencies. And we had somebody from CanMeds who was on that task force help us with that. And so by 1999, we came up with our models, released in February of 99, and then in 2001, we had the official launch, something called the Outcomes Project. And these are our 6 general competencies. And I'm sure if you've seen kind of comparison with CanMeds to ours to good medical practice in the UK, they cover, the good news is they really cover a lot of the same stuff. And so that's actually very reassuring that in all these different contexts, we kind of came down on the stuff that's really important to be a physician. But in these early days, implementation was really difficult. It was confusing. People had a really hard time getting their head around some of the competencies, in particular the practice-based learning and improvement systems-based practice, challenges that obviously still continue to this day. And then how do you take these competencies and turn them into a curriculum, right, and meaningful assessments? And what tended to happen was people would just kind of layer on the competencies onto existing systems. So for example, we had at the ABIM, this 9-point scale where you judge people on a 1 to 9, where 1 to 3 is unsatisfactory, 4 to 6 was satisfactory, and 7 to 9 was superior. And so we used to have things like physical examination, history taking, humanism, medical record documentation. What we did is we just stripped those out and we just added the competencies, right? That's pretty simple. So we'll just put the competencies in there instead and we'll rate them on a 9-point scale. That didn't go very well. And part of it was the problem with the scales themselves. It's what David Batt of Australia calls a strange form of encryption to which nobody has the code. And I think that's true. You know, some of the work that I've been involved with about how these things get translated really highlight the problems. And thus you're beginning to see this shift to more entrustment or developmental type scales, which have shown a lot of promise, and I think we're beginning to see some dividends from that. And they've also helped with the shared mental model. So for us, we then began to move into this next accreditation system. So in 2005, 2006, the ACGME said, all right, it's really time to get serious. And we're going to have to figure out how to operationalize this better because the kind of only bottoms-up strategy was really challenging. And so in 2012, ComNASCA really published what the journey had been those previous 5 years. And we began to move into milestones. And the main purpose of the milestones was really just to try to make sense of what the competencies were in developmental terms. So let me just describe a little bit about that. So here for us is an important framing slide as we think about the professional self-regulatory assessment system in the US. I work on the right-hand side. As you know, in the States, accreditation and certification are separate functions done by independent organizations. Our primary unit of analysis is the program, and we have the 24 boards who are loosely configured under the American Board of Medical Specialties. Obviously, here in Canada, those two functions are housed under the Royal Colleges. And we're the public-facing arm of the professional self-regulatory system. But here's the bottom line, as I'm sure some of you heard me say this before, is that we're only as good as what happens inside the institution. In the United States, if you can pass the licensing exams, and if you leave training program insufficiently prepared and worse yet can't get certified, you will practice medicine. Anybody want to guess who they take care of? They take care of the poor, because that's where they get a job, right? The market forces drive them into areas where they're taking more care of more disadvantaged patients. We've actually done that work and found that out. So we're very interested in figuring out, which is a new role for an accreditor, how do we facilitate change inside the box here? And so the combination of assessments is really critical. And so, you know, Marku talked about the importance of curriculum mapping, absolutely, and how those assessments fit into that to give you a sense of where you need to be. And then we have these important actors in the system, faculty, program directors, and others who are providing information using one of these tools. But the other part that's really important, and again, I was so pleased to hear about, is that we forget about the residents and fellows as active agents in the system. In fact, competency-based medical education doesn't work without them being activated agents. It just doesn't. And we're beginning to use this concept of co-production, which I won't get into a lot today, but happy to talk about more about how do we co-produce the learning experience with the residents, because they have to be active agents in this process. They provide input as well into the program. And then ultimately we take that data and it's synthesized through the Clinical Competency Committee. We've now had 4 years of experience with this, and we've done a couple studies. And when this process is done well, it clearly can make a difference. It can identify people earlier, it provides more useful and specific, rich information back to the trainee. When it's done poorly, you might expect it doesn't lead really to any better decisions. And the other point we make about this system is judgment still matters, right? Judgment's an important part of what we do. There is no magic brain scanner to determine proficiency or competence at the end of training. It's a judgment. And you want it to be an informed judgment using really good assessments against a rubric about what we define the outcomes to be. For us, those are now the milestones, and increasingly other specialties are also using EPAs. And that judgment should lead to feedback loops for both the program and the resident, right? So this is kind of our overarching kind of framework. For us, our milestone journey began, believe it or not, in November of 2007. Internal medicine went first. We began that work in Philadelphia. We used a very much community-driven process. We even brought in other health professionals into that conversation. And the whole goal was really to create a shared mental model. What was most powerful about that experience, honestly, wasn't the document that came out of it. Being internist, the original draft was 40 pages long. That probably wasn't going to work. And so obviously they had to go through a series of refinements. But what the community realized, it's the first time that actually had a conversation about what everybody expected at its core an internist should look like coming out of a training program. We had 393 plus or minus programs in internal medicine in the United States. We had about 450 ways of training an internist, okay? And so we had to move past that. So we put our first draft out in 2009. They were reconfigured, and starting in 2010, all specialties began to work on developing milestones for their specialty. The challenge here is that we gave them a lot of latitude. There was pros and cons to that. As a result, we have all kinds of milestone sets, and that's been a challenge to manage that. And moving forward, we'll have to address that because we don't have a core across all disciplines. They were pretty much left to their own devices. And by 2014, everybody was in the system. So this is kind of what the process looked like. They took these general competencies, they did a specialty translation and turned them into milestones. And for us, we are heavily influenced by the DREYFUS brothers, who were actually part of the original task force in the 90s. Hubert and Stuart DREYFUS actually served and helped David Leach and Paul Batalden develop the competencies. And that really has influenced the structure of the milestones. This is just the way development actually occurs. We know learning curves actually aren't a nice linear straight line. They tend to be more sigmoidal. And we forget that during residency and fellowship, our residents are spending most of the time on the steep part of the curve, interestingly, right? So they come in either as a novice, advanced beginner, somewhere in there, and then they work up that steep slope during the 3 to 5, 7 years, whatever it may be. And again, we know that the journey is not linear and some people are going to struggle. And the goal is to identify that person I read earlier. This is our general architecture of a milestone. They're just described in levels. The levels roughly correlate with the 5 levels in the DREYFUS model that I just showed you. The milestones are actually the words within the levels. People use shorthand for what is called a sub-competency. In this case, just being able to take a history, appropriate age for age and impairment in physiatry. The other important thing for us in our system is that milestones are actually a low stakes part of our system. They are not high stakes. There's actually important firewalls between these 3 elements. So the boards do individual certification, and that's done separate of our organization. And then the ACGME has residency review committees that actually do the kind of work of accrediting programs. And they use now different type of metrics, essentially faculty and resident surveys. They track board certification rates, scholarship activity, and then that kind of is fed into a composite. And then the review committees look at how they're doing, and those what we kind of call safety metrics to make a decision as to whether or not they need to do a site visit, intervene, etc. Because right now we don't plan on doing site visits except for every 10 years. And the site visit is now called a self-study site visit, where it's really designed to think about what have you learned during this time and how can we make things better. And they now report this data annually, and so it's more of a monitoring system, where in the past we would go on site every 5 to 6 years and kind of do this deep dive. And with a heavy emphasis on process and structure type stuff. Do you have a call room? How many blocks do you have in this? How many half days, et cetera. This wasn't getting us to where we needed to be. We knew that. And then the other part, the 2 other parts of the system, which are also firewalled off from the review committees, are milestones and something called the CLEAR program. So CLEAR stands for Clinical Learning Environment Review, and that is a low stakes kind of visit to figure out how well the residents and fellows are being incorporated into things like quality and safety activities, what's the environment, professionalism, etc. And that information is actually fed back to the C-suite at the hospital, right? To get them to understand that the residents fellows are a major part of their workforce as they're learning, and they need to be incorporated as part of a valued member of the institution. And they talk about how to do that. And so that's different. There was thoughts early on that milestones would shift into a high stakes endeavor for accreditation. We begin to look at those outcomes and how many, for example, reached a certain level. We're beginning to rethink that actually. And I'm going to show you why in a minute, why we think that may not be the best model and how we're going to handle that. So let me just share a little bit about our milestone experience. One of the things that we're using to guide our work is obviously validity. This is the MESIC validity framework. This is a nice slide from Stan Hamstra, a Canadian, who's now working with us and helping to lead our research efforts. And so we kind of take a look at each of these 5 components: content, internal structure, response process, relation with other variables, and consequences. And you can see some of the elements on here that we've already begun to look at, and I'm going to share some of that early data. As I said earlier, this is the general structure of a milestone, and for us, level 4 for most specialties represents a recommended, not a required, graduation target. Right? So within the discipline, within the 6 general competencies and sub-competencies, the goal for the resident is to achieve level 4. And so when they were building the milestones, it was really, the groups were instructed to write level 4 as if that was proficiency, right? That this is where they're really ready to be good at this. So one of the things we were worried about when we were going to look at the data in the first year, because we got our first year in data in June of 2014, was, okay, everybody's just going to be marked at 4, right? We're an accreditor. It's kind of high stakes in the sense that if you're not accredited, you don't get federal funding, and nobody likes being on probation, all kinds. You can just imagine, right, that a regulator is saying like, oh yeah, it's just a recommended target. Like, sure, it's a recommended target. We're just going to make everybody a 4. So we were really interested. The good news is that didn't happen. In fact, it didn't happen across any of the specialties. And the one that really stood out was neurosurgery. And so this is a really interesting slide where in neurosurgery for patient care, what you would put under medical expert here, were 8 domains of neurosurgical procedures. And what we found was that about the 120 residents who graduated, remember this is a 7-year program in the States, only 54% of them were deemed to have reached level 4 in all 8 domains. What they said is core in neurosurgery. We're like, okay, that's kind of horrifying, right? After all, this is brain surgery. And when we actually teased back and looked under the hood, what we found actually was really valuable information. So as you might expect, that we have a certain number of programs, but not everybody has sufficient clinical exposure to all domains, as it turns out. And the 2 that were lowest were pain and peripheral neurosurgery and then surgery for movement and epilepsy, movement disorders and epilepsy. And so when we began to talk to the programs, they said, well, you know, this doesn't surprise us. And as a result of this data, where you can see the patterns here for the 8 domains, they're now having a national conversation about what are the implications for neurosurgery training. Should pain and peripheral neurosurgery be core? Or are we okay with most of them reaching a level 3 so they understand it, right? They have a certain level of understanding, maybe competence, but they would never be the ones to, you know, kind of drive that surgery. Maybe they need to flow into fellowships earlier. So it's triggered a whole series of conversations in that community. And so that's, for us, that was kind of a nirvana moment, that even though this is likely still on the lenient side, it created a national signal that said we need to take a look at our training. And it turned out, ironically, just around the time I had a chance to meet a neurosurgery resident from the University of California, San Diego, and I just asked him about his experience. He said, oh yeah, I said, we only have one person here who does epilepsy surgery. There's just no way in hell that I'm going to do it. I said, I had a chance to spend a month on it, but I'm not qualified to do it. And so, you know, that was a really wonderful thing for him to hear, that like, no, I know kind of where I am developmentally, right? Those milestones help me do that. And I'm coming out as this package in neurosurgery. So now you can see it has workforce implications. You know, we need those kind of people to do that surgery, but where is it going to be done? How are people going to be prepared? You just can't assume that everybody coming out of neurosurgery, which would have been the model in the past, by the way, right? Theoretically, when they're certified to do all 8 things. Now what they're recognizing is, no, we need to be very clear with the resident when they leave. This is what you are, right? This is the package that you take with you where you're ready, you're proficient to do these type of procedures. So that's been really helpful. Not quite sure what happened there. We've also had some early validity work, and this has been exciting. This is from the emergency medicine crew. The EM docs in the state, to me, have been just a phenomenal community. But you know, when I meet people like Damon, it doesn't surprise me. The EM docs are really kind of a remarkable group. And so they were all over this right out of the gate. And what they did is that around 2007 to 2010, they worked very hard on their practice model. And so the milestones were very much, and the competencies are very much aligned with their practice model in EM. And what it turns out is that they have kind of a 3-component model that they look at. And so we looked at the milestone data even in the first year. You can see, by the way, all of them have ridiculous reliability coefficients, because when you're collecting data on 127,000 trainees every 6 months, you're going to get high reliability. So just to make that clear. But the nice thing is, when they did the factor analysis, guess what? It held up in the 3-factor structure, which is great. That's the way they designed it. That's the way they got used. So that was really helpful. And you can see that there's nice distributions. The solid line is the PGY1s, then you got the 2s and the 3s. Some programs in the States are 4-year programs. And so, and you also kind of saw these kind of, you know, not normal, but, you know, certainly more bell-shaped, which we hadn't seen before. Everything before was like just narrow, right? Because of that 9-point scale. Everybody was a 7, 8, or 9. So that was really encouraging. This study just came out in December on the JAMA medical education issue. We had this opportunistic experiment where the American Board of Internal Medicine was still using that lovely 9-point scale I just described, and we could compare it with the milestone ratings. And as you can see, I've just pulled 2 examples here. These are the composites of the SUB-competency, but you can see the trajectories look very different. for systems-based practice and practice-based learning and improvement. And we saw that across all the sub-competencies, basically suggesting that you're seeing, and faculty are more comfortable with the milestones, giving people more variable ratings, more developmental ratings. And that's very encouraging. We're certainly hearing that in their qualitative work. We're just finishing up the analysis of a longitudinal study where we interviewed 25 programs at 4 points in time to learn what their trajectory looked like. And those are the things that we're hearing. The other thing that was really interesting is that we were also able to correlate these ratings with the certification exam performance. And it turns out that ratings on the milestones were more sensitive or better predictors of how somebody was going to do in the certification exam. The graph on the left here is that 9-point scale, and you'll notice it actually starts at 4, because it turns out in the ABM system, you have to have a rating of 4 or above in your third year in order to be eligible to take the exam. Because remember, 1 through 3 is unsatisfactory. That doesn't fly for board eligibility. Whereas on the right-hand side, that's the entire scale. So you can see there are people down there, there are outliers, that even at graduation were basically judged to be somewhere between level 1 and level 2. Advanced beginner, a little less incompetent, that somehow got through the program and, say for one individual, did not pass the exam. So it's more sensitive, if you will, in picking people up, and that was good to see. We've also done a fair amount of qualitative work. These are the kind of early positive impacts. The quantity and quality of feedback to residents has gone up, and guess what? They like it, just like you heard here. The CCC process, when done well, has been extremely helpful, improving not only assessment, but dealing with residents in difficulty. The curriculum, it's been helping people to recognize gaps in curriculum, to change the nature of rotations. Faculty development has also been a nice dividend where it's improving how we work with faculty. And then people really like the continuous quality improvement nature or philosophy of the system. So this isn't about getting it right out of the gate. It's about making things better continuously over time. And that's really what this system's designed to do. As you might expect, there's been some also major challenges. Logistics of data collection, very much like what you heard here, has been challenging. There are some really promising IT tools that are also being used in the States. I'm happy to discuss those more during our panel conversation. We also have a real problem with getting data into our system. People have to enter it manually, and that's just a pain in the neck. And so one of the things we're going to have to work on over time is how can that more directly be transferred out of their learning management systems into our ADS systems. But we're now having the ability to work with data in ways we never did before. Assessment process has been a huge challenge. Some milestones actually use negative language. For example, surgery and internal medicine have a column called critical deficiencies. Some faculty don't like that, others love it. And so that'll be something we'll have to look at as we move forward. And then synthesizing the multiple assessments into a judgment's hard. We've never really had to do that before because you just can't add stuff up necessarily. You still need to have a conversation. It needs to be a systematic, structured conversation in the CCC to do that, and some people are struggling, particularly if they haven't changed their assessment forms. If they're using those old style forms, every intern's at 7, 8, or 9. Where do you put them on a milestone development, right? Well, let's see, if they're 7, I guess that means they're a level 2. If they're an 8, they're a level 3. I mean, it just doesn't work. And then time and resources. This is a direct quote from a program director. RVUs, for us, that means relative value units always win, right? So it's a huge challenge. So this is kind of where we're headed to build on this early work. We're going to continue to work on the content. We're now beginning our process of revision for 2.0. We're looking at the factor structures to help guide that work in 2.0, and certainly looking at reliability and internal structure. We're also very interested in continuing to help the clinical competency committees improve their work. We've had some early work we've done with Karen Hauer. I mentioned the one study we're doing with ABIM about learning what are some best practices for CCC, and we'll continue to do that. By the way, that's actually a study we're exploring doing collaboratively with the Royal College here in Canada. We're actually very excited about that. Rater processes is a big deal. Not only the quality of the assessment tools and getting them better aligned, but also the culture change aspects, as you heard. For some of the older faculty, to be honest, they're the group that tends to struggle the most. It's hard to let go of that mental model that they were socialized in. I totally understand that. I'm that guy. Right? I'm old. So, it's hard to let go of some of that stuff that you were really comfortable with and say, we need to do things differently. And then we're beginning to do some predictive validity work that we're pretty excited about. We're now reaching a stage where we can begin to see how they're actually performing in practice, take a look at what they actually do, and how does that correlate with their experience during training. So that's still a year or two away, but we're now setting up the processes to do that. Let me just end, I think, with what I think you heard in spades, again, from the three wonderful speakers who started us off. It's really about the implementation. I think for us right now, for most folks, we've moved past the why. Why are we doing this? I think most people understand the importance of the competencies, the need to attend to stuff we didn't before, like quality, safety, systems, etc. But boy, getting this to work is difficult. And so it takes time to do that. And we're using a couple frameworks to help with that. One is what's known as a realist framework. This comes from the social sciences, Ray Paulson and Nick Tilley, who interestingly began this work in, of all things, criminology in the 1980s. And what they were interested in is why crime prevention programs worked in some communities and not in others. And what would happen was they would randomize these communities to certain interventions, and then the net effect would be zero. And the conclusion would be, well, this crime prevention program doesn't work. And their genius was, well, wait a minute, it worked great in Bristol, but it didn't work in the suburb of London. We're just going to throw the whole thing out? What happened in Bristol where it truly made a difference, but not in this community? And so they came up with this important set of questions and framework. What works for whom in what circumstances and why? As you can see from the slide, an action is causal only if its outcome is triggered by mechanism acting in context. So what they realized, you got to really pay attention to the mechanisms by which an intervention works or doesn't. So for example, my intervention might be a multi-source feedback tool in the intensive care unit. What are the mechanisms by which it will get used in the unit? Who's going to fill it out? How are they going to fill it out? How am I going to choose people? Where does it fit in the workflow? All the stuff you just heard about. And oh, by the way, context matters a lot. Is the institutional culture supportive for more assessment? Is it going to provide more time? Those sorts of things. So this is, I think, a really helpful way to think about what we're trying to do. The other work that Ray Paulson and Tricia Grinhage talked about, kind of using complexity science, is that they look at what we do in education as a complex service intervention. I think this is a really helpful model because we don't use just one thing, right? You think of all the components that were just described in these programs. There are multiple components to what they're doing. It is truly a complex service intervention, and all those components are interdependent. They don't function in isolation. So I think there's a couple things here from this kind of theory that might be helpful. The first is intervention process matters. CSI functions through theories, right? So our educational theories we're using are actually really important. And the hypothesis is if we deliver a program in this way, then it will bring about some improved outcome, okay? So the tension with the intervention process is the fidelity, right? Is it implemented as intended, but at the same time, it has to have some ability to adapt. And we'll come back to that. CSIs are active. They achieve their effects by the active inputs of individuals. And in our case, lots and lots of individuals, right? And as Paulson points out, one of the problems with using a randomized controlled trial design is that guess what? Passive control groups do not contribute to learning about implementation. And so we have to rethink some of the research models we use. Here's one that I think will probably resonate, particularly with Marku. Success must be longitudinal. Complex service interventions, quote, have a long journey. Their ultimate success depends on a longitudinal cumulative combination of events. So in other words, this is like the ultimate plan, do, study, act cycle that you see in quality. And there'll be multiple cycles. And it's always refining and revising. And that's since the work's never done. They're nonlinear. CSIs have a nonlinear implementation chain and one that can even go in reverse, particularly in the early implementation of innovations. Oh, implantation, where that came from. Implementation, sorry. It's known as regression, the J-curve. That'd be interesting if you implanted it. I might explore that as a possibility. And then context matters a lot. And this is something to me that it really just hit me right between the eyes when I read this. CSIs are fragile. They're embedded in multiple social systems, and therefore not all programs will be equally effective. because of the critical importance of context. I think we have to recognize that fragility, right, and the importance of the nurturing of any change we make, being able to adapt and change things that aren't working. But that fragility, I think, is a helpful concept. And then two more. CSIs will mutate according to local conditions. They are leaky and prone to be borrowed. The same intervention will be delivered in mutating fashions shaped by refinement, reinvention, and adaptation to local circumstances. As I thought about family medicine with 350 residents, my head exploded, right? I mean, they're just going to look different in these 14 sites, and you have to have that adaptability. And then finally, CSIs are open systems and they feedback on themselves. They're constantly looping. And the intervention, once you put it in, guess what? They change the conditions under which you started, right? Doesn't stay the same. And so once they're implemented, you'll see these changes. So I hope this has been helpful, and I'm happy to share anything more you'd like to hear about our journey, but much of what you heard from the three panelists, we're experiencing the exact same thing in the States. And I think that thinking of this as a long journey, I think will be really helpful. So again, thank you for having me. It's always a treat to come up and see you.